Sujitra, I think we can go ahead.
Okay.
Atul, hope the meeting is being recorded.
So, good evening all. Welcoming you all to the Family Medicine Orientation for PG students, organized by Spice Road Kerala chapter on the occasion of World Family Doctor Day 2026, which is a curtain raiser event for Spice Road Conclave 2026, which is happening for the first time as a part of FMBC. I'm very much sure that you have doubts regarding what is this Spice Road, what is this FMBC, and what is this Spice Road Conclave. I'm very much sure that you will get the answer for these questions at the end of today's session. So, first of all, this is not at all an academic event. The primary aim of today's program is to help new and existing FM residents to understand what is our specialty, what is the core and basis of our specialty, and the practical approaches of our specialty. Very often when residents enter family medicine, they encounter several questions like what exactly is family medicine, what is the role and identity of us as family physicians, what is our approach different, how our approach differ from other specialties, etc. So dears, I'm very proud to say that today's program has been carefully designed to address these very questions in a structured manner. Keeping all these important aspects in our mind, I will give you a brief idea about today's session, which have been planned sequentially to give residents a comprehensive orientation to the specialty. So we will begin with a session on scope and identity of family medicine by Dr. Aishwarya V. Nambudiri. And at the end of the session, you will understand that family medicine is not limited by an organ system, a procedure, or an age group. It's a highly skilled, academically structured, and specialty-based discipline that forms a backbone of healthcare systems across the world. And this will be followed by Dr. Vishnu P.S. speaking on introduction to key organizations in family medicine. See, this is one of the most beautiful part of family medicine programs, which makes it differ from other specialties. This session aims to introduce residents to important organizations which have played a major role in strengthening family medicine education, advocacy, leadership, and to understand how becoming actively involved in these organizations can open opportunities for academic growth, networking, leadership development, and collaborative learning with peers and senior faculties from different parts of the country. Next, we have Dr. Sajida ma'am's session, which will guide us through the corner foundation of our practice, the core principles of family medicine, one of the most important session planned for today. This is what makes family medicine a holistic, humane, and deeply patient-centered specialty. Understanding these principles early during residency is extremely important because they ultimately define our identity and our clinical practice. Following that, Dr. Hemavati ma'am will discuss the three-stage assessment in family medicine, one of the defining property of our family medicine specialty, which makes it differ from other disciplines in our clinical practice. It changes not only how we understand illness, but also we communicate, counsel, manage, and follow up our patients. And then we will have a session by Dr. Rishmi ma'am, speaking on the curriculum, exam overview, and academic aids, which is an unavoidable session as residents. Since academic preparation in family medicine also requires a slightly different strategy, residents need proper guidance regarding how to prepare academically, proper guidance regarding standard textbooks, exam patterns, and academic aids, and you will benefit through this session by this. Finally, Dr. Jay Ganesh will conclude the session with opportunities and networking in family medicine, highlighting the many possibilities available for growth within the specialty. So, concluding this, let me once again welcome you all to the today's session. And I'm inviting Dr. Aishwarya V. Nambudiri to talk on the scope and identity of family medicine, who is a specialist and Department of Family Medicine, KIMS Health Trivandrum, immediate past chair, Spice Road Kerala, and executive member of AFPA Kerala. Welcoming you, ma'am.
Is my screen visible?
Yes.
Okay. Thank you, Dr. Sujitra. I welcome you all to this wonderful session. So without further delay, let me go into my topic. So the topic is regarding identity and scope of family medicine. So first of all, let me welcome you all to your postgraduate journey. Those who are new here, welcome to this branch. It is one of the most fulfilling branch that happen to you. So this is going to be a really good journey. So defining the identity of a family medicine specialist. So a family medicine specialist is the ultimate generalist. That is, he or she has the professional responsibility for unselected patients with undifferentiated problems. And it is mostly focused entirely on the whole patient and not just the disease. And the family physician is the first point of contact who can manage around 80 to 90% of all health conditions in a community. So thereby providing holistic and comprehensive care to the patient. So these are the pillars of family medicine. You will have a detailed session later. So the pillars are comprehensive care, continuous care, coordinated care, contextual or family-oriented care, and preventive care. So for example, you are able to manage the symptoms of the patient. You are able to manage their chronic diseases like diabetes, hypertension. You are able to coordinate their care with their subspecialist. You are able to advise their family, give family counseling. And most importantly, you are also able to advise on the preventive care. Suppose a patient whose father has a history of CA colon, you can advise the patient that after the age of 40, 50, he has to do a screening colonoscopy. Likewise, a patient with family history of breast cancer, a female, you can ask them to go for a mammogram. So there are so many things that a family physician can do, and it's a privilege. So coming to the Indian healthcare and medical ecosystem, the healthcare dilemma in India is that the care is really fragmented. We all know that patients are now over-consulting subspecialists for minor common health issues. There is this rising healthcare cost, giving rise to a lot of high out-of-the-pocket cost for unnecessary investigations. Suppose you are going to a subspecialist. Suppose, for example, the most common example that we give is that of a headache. You're going to a neurologist for your headache, and the neurologist has definitely got to rule out the neurological causes, and he may order a CT or MRI, and so this will, cost you a lot, and this reports may be normal, and the investigations may be unnecessary. And now there is this dual burden of managing both infectious diseases, and there is an explosion of chronic lifestyle illnesses in our healthcare system now. So the National Health Mission and the National Medical Commission are prioritizing family medicine for universal health coverage. I'm not able to move. Okay, so coming to the scope of practice or the clinical horizons. So a family physician can very easily manage the common infectious diseases, the non-communicable diseases or the lifestyle diseases, then common emergencies. They can manage the common problems that women face, then antenatal checkups, immunizations, newborn care. In my residency, I still remember there was a patient who was diagnosed to be pregnant in our family medicine OPD by my HOD, Dr. Rishmi. And that patient wanted her antenatal checkups to be done by a family physician. And so throughout the journey of her pregnancy, we advised her regarding blood test, antenatal checkups, immunization. And finally, in spite of being a tertiary care hospital, it was a family physician who managed her. And only towards the end of the pregnancy, we actually, referred her to the gynec department for safe confinement. So that is the power of a family physician. Now, care of children, we can manage the common ailments. We can do minor surgical procedures like wound care, excisions, foreign body removals, fracture reduction, take care of the mental health. And geriatric care and palliative care can also come under our care. And I would advise doing some kind of add-on courses after your post-graduation to broaden your knowledge in those topics. Most of these courses are not MCI recognized, but it will definitely help you in enriching your knowledge, especially if you're catering to this group of population. Now, coming to career pathways. So a family physician can easily have a private clinic, can head community polyclinics, be medical officers and chief medical doctor in peripheral medical centers of tertiary care hospitals. So here there is the ultimate clinical autonomy and high community impact. And in corporate and metros, we can have our own OPDs. We can give evidence-based preventive health checkups, home care services, geriatric and palliative care services. So here it is a highly collaborative network, and mostly the hours are all fixed and very stable. And in academics and public health, after doing 1 year of senior residency in medical colleges, you can be assistant professors, and also you can be teaching faculty or academic coordinators in family medicine institutes, project managers, etc. You can lead research and shape national health policy. Now, digital age is also the new thing. There are telemedicine networks. You can do remote triage platforms, and there is this borderless patient reach here. Now, this is just a snapshot regarding the current situation in our country. You can see that there are 68 DNB family medicine institutes, 33 institutes having secondary DNB, 108 diploma institutes, 8 MD-FM seats, 6 AIMS institutes having 16 seats, and totally the current number of students is around 1,254. And our community is continuing to grow. So another most important question that every family, every person who has taken family medicine has faced is, what is the difference between MBBS and family medicine? When I joined my residency also, on the first day itself, the medical director asked me, why did you choose family medicine? What is the difference between family medicine and an MBBS doctor? So I would say that at that time, I didn't have much of an idea. I told him I like all the specialties, that way I chose family medicine. But now I have a better idea. So the MBBS is actually just a basic entry level undergraduate degree, whereas family medicine is an advanced 2 to 3 years postgraduate specialization where you have, you work just like any other PG in the subspecialties and gain enough knowledge to practice. And coming to the depth of practice, an MBBS graduate is able to offer episodic care. Symptoms are addressed individually. And here also the tertiary care exposure is more, whereas the primary care exposure is actually comparatively less. Whereas a family medicine specialist is trained to give continuous lifespan care and can handle comorbidities and give patient-centered care. MBBS graduates will be quick to refer complex multi-system cases, whereas a family physician can resolve up to 90% of all clinical presentations. The key clinical skills for MBBS include giving standard first aid, general triage, and basic diagnosis, whereas advanced multi-specialty triage and minor surgical procedures can be done by the FM. And the scope of view, organ or pathology-focused perspective, whereas in family medicine, it is contextual, family, and community-centered. So while MBBS degree provide a basic foundational level of medical education, your postgraduate specialization gives you the depth to independently, resolve cases without immediately relying on subspecialist. So MBBS is usually limited to institutional medical officers, primary healthcare centers, or they just act as a bridge before chasing a post-graduation seat. Whereas family medicine's doctors are positioned as expert consultants in corporate hospitals, they are leaders of community polyclinics, faculty in medical colleges, or pioneers in telemedicine networks. So now coming to common myths and reality. Myth 1, family medicine is just extended MBBS. Of course not. It requires 36 months of intensive rotatory residency across critical specialties. So we learn more in depth about that specialty along with imbibing the principles of family medicine and patient-centered care. And like any other postgraduate resident, we also have to submit our professional thesis and undergo medical board examinations. Now, the second myth is that they are only OPD doctors. Reality is that they are highly trained. We are highly trained to recognize acute emergencies, coordinate complex inpatient transitions, and manage intensive palliative care regimens. And the third myth is that there is no academic growth prospects. Of course not. I just gave you all the data. Rapidly expanding national healthcare policies have opened major pathways to become assistant professors, clinical directors, and policy administrators. So the National Medical Commission, the NMC, officially prioritizes and protects the development of family medicine across India. So the legal framework mandates the Undergraduate Medical Education Board to prioritize family medicine and primary healthcare delivery, and orders the Postgraduate Medical Education Board to facilitate and heavily scale postgraduate seats in family medicine. So these are the 7 expert roles outlined by NMC. The family medicine specialist is a clinician providing comprehensive whole body medicine, a leader who effectively organizes and heads multidisciplinary clinical teams, a communicator building empathetic long-term patient relationships, a collaborator, scholar, professional, and social advocate. The Indian government and NMC explicitly recognize that our current health infrastructure is over-reliant on tertiary subspecialties, and as a result, It has legally institutionalized family medicine to create doctors who can manage resources and drive public health advocacy efficiently. So be proud that you have taken family medicine. It's a very beautiful branch. It is a lifelong journey, and I wish you all success. Thank you.
Thank you, Dr. Aishwarya ma'am. Next, we move on to the next session by Dr. Vishnu B.S., who is the National Chair, Spice Road Movement, Academic Coordinator, Department of Family Medicine, KIMS Health, Trivandrum. Welcoming you, sir.
I hope my slides are visible.
Yes, sir. Yes, sir. Visible.
Yes, sir.
Just a minute. Thank you, Dr. Sujitra and Spice Route Kerala team for having given me an opportunity. So the topic that I'll be dealing in next 10 to 12 minutes is introduction to the key organizations in family medicine, which we all should be knowing about. I'm Dr. Vishnu. I'm the specialist and academic coordinator at KIMS Health Trivandrum, the current regional chair for Spice Route South Asia region and the national chair for Spice Route India movement. So first thing is why I chose to take this topic today is I have been hearing so many questions over the last 1 to 2 years. What is this Wonka? What is this AFPI? What is Spice Route? That is the most heard question that I have encountered in the last maybe 1 or 2 years. So I thought it is an app platform where I should be elaborating what exactly all these are. So Wonka was first coined in 1972 as a World Organization of National Colleges, Academies, and Academic Association of General Practitioners and Family Physicians. So as you can see, it is a long sentence, which finally we made it shorter to as the World Organization of Family Doctors, but the acronym we written as WONCA, which is the one global family of family doctors across the 7 regions with one mission, that is better health for all through a strong primary care. So WONCA defines who is a young family doctor. As per the bylaws, it is a person or a family medicine person in training or in their PG residency or completed the training and in first 5 years of medical practice. That is what WONCA defines for a young family doctor. A person in training or completed the training and in the first 5 years of practice. In the previous slide, I told you that WONCA has divided itself into 7 regions. That is Africa, Europe, South America, North America, East Mediterranean, Asia Pacific, and South Asia. And for all these regions, we have a young doctor movement. So for Africa, it is the AfriOne. Europe was the first young doctor movement to be formed, initially called as the Vasco da Gama movement, but later it was renamed into the European Young Family Doctors Movement, or the EYFDM. In North America, it is called the Polaris. South America, it is called the Wainake. Asia Pacific, it is called as the Rajkumar movement. East Pacific, East Mediterranean, it is called as the Al Rasi movement. And in South Asia, it is called the Spice Route. So all of you who are attending this meeting should know that Spice Route is the young doctor movement for family medicine or family physicians in South Asia. So as I said, there are 7 regions. The 7 regions have 7 leaders. And on top of us, there is a global lead, and currently Dr. Fabian Dupont from Germany is the global young doctor movement lead, and he's a professor practicing in Germany. And there are 7 regional leads, Dr. XC for North America, Dr. Daria from France for Europe, Dr. Michael Angelo from Philippines for Asia Pacific, Dr. Ana Perez from Mexico for South America, Dr. Ibrahim Benaru from Nigeria is the lead for Africa, Dr. Yusuf Khalid from Palestine is the lead for East Mediterranean, and South Asia region as of now is led by me. So after 2013, India is having an opportunity to have a regional lead. And if you ask me which are the countries that comes under the South Asia region, these are the 7 countries, that is India, Sri Lanka, Pakistan, Bhutan, Bangladesh, Nepal, Afghanistan, and Maldives. And what from the past few years experience, Afghanistan and Maldives have not been that active, but India, Sri Lanka, Pakistan have been very active in family medicine perspectives. So also Bhutan, Bangladesh, and Nepal. What is our mission? So it is to connect the young doctors across South Asia to promote education, collaboration, and innovation, and advance primary care for a stronger, healthier communities, and be the voice of the young doctors in the regional and global platforms. And when it comes to Spice Route movement, it was first formed in 2010 and officially inaugurated at the Kathmandu conference. And the logo was first designed by Dr. Ramnik Parikh. He's also from India. The logo was modified in 2023. And the first chair of Spice Route is Dr. Raman Kumar. He is the current Chairman Emeritus for Academy of Family Physicians of India. So coming to the regional council or the South Asia Regional Council, I am the regional chair, and with me is Dr. Hazam Khan from Pakistan, who is the secretary. Dr. Parami from Sri Lanka is the FM360 coordinator. Dr. Kinli Bhuti from Bhutan was the immediate past chair. Dr. Abul Bashir from Bangladesh is the treasurer. And Dr. Anuna, she is also from India. She is the image editor. And Dr. Bigyan from Nepal is the Aspire lead. If you might have known, many of you have attended the Aspire leadership program by the Wonka YDM that was inaugurated officially by Dr. Viviana yesterday. Maximum representation for this Aspire program was from the South Asian region. We had 39% of the total representation of the 175 participants who have joined for the program. Actually, it was screened from the 300 plus applicants. Coming to the national team, this is the National Spice Route Movement team with Dr. Anuna along with me as the secretary, Dr. Bharat Sarguru as the FM360 coordinator, Dr. Amaran as the PG coordinator, Dr. Atul as the image editor, and Dr. Prince as the treasurer. And our advisors are Dr. Seren Kuriakos and Dr. Jyotika Gupta. You all who are attending should be knowing who all these people are. And when I tell about Spice Route, it is very important that I mention about our mother organization, that is Academy of Family Physicians of India. And shown in the image is the pioneers in family medicine in the country, Dr. Mohan sir, Dr. Reshmi ma'am, Vandana ma'am, Dr. Raman sir, Abhijit sir, Dr. Seren, Dr. Jyotika, Dr. Kiran Mai, and Dr. Venkatesh sir is missing in the picture. So all these are the pioneers currently leading Academy of Family Physicians of India, which is the parent body for family physicians in the country. We also have the respective state chapters. We have so many active state chapters, and as you know, the Spice Route Kerala chapter is hosting this meeting. Likewise, we have so many other state chapters doing many activities in its own capacities. Now, what are the objectives of Spice Route? It is to improve and educate and improve the training of young family doctors, to increase the opportunities to develop skills in research and publications, to give a platform for young family doctors to share their concerns, their doubts and aspirations, and how we can help them, and to encourage leadership through participation in various Spice Route activities and execute structure. If you have noticed, we have a national platform, we have so many state platforms. So all of you who are interested can be a part of Spice Route through either of this or one of this body. You can be active in the Spice Route and involved in the day-to-day activities. Now, what are the activities we usually do? We do conduct pre-conferences. We do have workshops or symposia. The social media activities you all might have seen, even though many of you don't know what Spice Route is, you might have seen the flyers of Spice Routes spreading every other day around. So we have social media activities. We have FM360 exchange programs, fellowships and socializing events, PG orientation programs, PEOs or the practical exam orientation session, which is a highlight event for Spice Route, online OSCE sessions, the Spicy Tuesday campaign, which is again another important promotional activity of Spice Route. We release family medicine revision snippets. So all these are the activities that have been undertaken by the Spice Route over the last few years. So these are some of the flyers which you might have seen. This is the Spicy Tuesday campaign. Initially, as you see on the right-hand side, it is the member of the week initially. As we grew in numbers, it changed to the Splendid Schools of Family Medicine, where we tried to introduce the various institutes running the family medicine course in India. And as we progress, now we have the sneak peek into the family medicine departments, where we try to introduce the family medicine residents in various institutes across the country. So this is what I mentioned as the practical exam orientation session, or the PEOS, which is exclusively aimed for the family medicine trainees. So altogether, we had 9 sessions that was conducted over the last 2 years or 2.5 years. Starting from July 2023, we had the first session at Lutz Hospital, Kochi in Kerala. And we had total of 3 sessions in Bangalore, 3 sessions in Delhi, 2 sessions in Kerala, and 1 in Jaipur. So total of 9 sessions, which were attended by more than 450 plus residents across the country. And this is a photo from the last session that we had in August 2025 at Lutz Hospital, Kochi. We had a leadership training program which was held in 2022 in the houseboat at Kasaragod in Kerala, which was attended by around 50 plus delegates across India. So we conduct pre-conference event. This was the one that we had in association with FMPC 2024, which is the 6th National Conference of Family Medicine and Primary Care that happened at Rishikesh in 2024 September. We do appreciate the chapters which do or which perform well. These are the best chapters in 2022 and 2024. We give bursaries for young family doctors and residents to attend international and national conferences. This was the bursaries that we have given for 2 people to attend the WONCA South Asia conference that happened in Bangalore. We do conduct Spice Route meet and greet sessions, wherein some of the leaders in Spice Route and Academy of Family Physicians of India, or AFPI, when we get a chance, we visit the residents, the young doctors, we spend time with them, we address their concerns. So it is a forum where we can interact with our juniors and colleagues. We do get opportunities to be a part of conferences. This is the WONCA SAR 2024 conference that happened in Sri Lanka, where there was an exclusive YDM event and dinner. And we hosted the 2025 WONCA SAR in Bangalore. Again, we had an important role for Spice Route to be played. And of course, we get platforms in the international arena. This was Lisbon 2025 September, where we got a chance to be in Lisbon, interact with the international leaders from various countries, and know what family medicine and how it is practiced in the other countries. Of course, we had previously exchanges, but it was in a standstill state. But we revived it, and now we have the FM Compass, which is a FM 360 exchange program, wherein a person who is practicing in one area can get to know more about how family medicine is being practiced in the other parts of the country, other institutions. As of now, we have localized 4 to 5 institutes in various parts of India, where residents who are interested to attend can go spend 1 to 2 days and learn how things are practiced or done in a family medicine practice in that institution, and adopt them in their own clinical practice. So this is the FM 360 exchange program called as the FM Compass. Now, how we can interact with you all, or how you can interact with us. So we have a WhatsApp group for the current family medicine PGs in India, which has 622 members. We have another group for post PGs, which is the YDM group, where we have around 375 members. There are respective state groups for most of the states. We have the state chapter groups. We have a Spice Route India community with 1019, that is 1019 members. We have an YouTube channel. Even this meeting has gone to its full capacity, that we are live streaming this event in YouTube. So you can avail all the activities of Spice Route through the YouTube channel. And if you have not subscribed, please do now. And Of course, there is a recognition for what you're doing. Dr. Seren Kuriakose was the regional secretary of South Asia region 21 to 23. I was the FM360 coordinator 23 to 25. Now we have two members from India representing the South Asia Council. And 2 times we could win the Spice Route South Asia Rising Star Award. Now, what are the goals for Spice Route in 2026? It is to prepare. We have to have a database of our members. So the first target is to prepare a database of the family medicine residents across the country. We have to sort it institute-wise, state-wise, and wise. And you all might have received a Google form that I have prepared and sent to all. Just take 2 minutes. Those who have not filled, kindly do it at least by today. It takes just 2 minutes to fill it up so that it will be useful for us to help you out, to communicate to you, to let you know what are the activities that are happening. We already have so many active state chapters. The other goal is to mobilize the old chapters to a better state and initiate the formation of new chapters. 5 chapters we are planning to start or activate this year is Delhi, Maharashtra, Uttar Pradesh, Jammu Kashmir, and the Northeast as the first step. And in other places, we plan to start with the coordinator support to a smaller extent and expand it in the coming years. And our pioneer target for this 2026 is to conduct the first national Spice Route conclave successfully at Madurai during the FMPC 2026. And as Dr. Sujitra highlighted in her opening remarks, this event that you are seeing today is the curtain raiser event for the Spice Route India Conclave 2026, happening in September 25th, 2026 at Madurai Meenakshi Hospital in association with the 7th National Conference of Family Medicine and Primary Care. So it is my humble request, all of you to kindly join us, be a part of the largest event of family medicine in the country, that is FMPC 2026 and the Spice Route India Conclave 2026. Let us all join together, meet there, share your concerns, get along with your colleagues, know your seniors, and this is the best opportunity for you. Thank you.
Thank you, sir, for this wonderful session. So without wasting time, let me move to one of the most important session of today's program. That is core principles in family medicine. Let me welcome Dr. Sajida M. of Rahman, ma'am, Professor, Department of Family Medicine, CMC Vellore, for the session. Welcoming you, ma'am. Shall we start, ma'am?
Time to share. Okay. Okay, sorry for that initial glitch on my side. Now, good evening, everyone. Hello to AFDA Kerala chapter, the most active chapter in the country, I suppose. Hello to Dr. Vishnu. Hello to Dr. Rashmi. It's been quite a while. But to organizing the session, many thanks to having me here. And interestingly, what I want to share is the information that I have listened to in the last half an hour or so. It's a big organization. It's a lot of work that has been put behind the scenes to make family medicine be much, much more feasible to be understanding to the residents. When I joined in 2010 with an MD family medicine, the question which was asked to me in the couple of places where I applied was, what is family medicine? And do you want to continue in family medicine? And eventually what I was offered was, can you be in a position in internal medicine? But whatever little of what I understood of family medicine at then was, I chose family medicine for multiple reasons, for very simple reasons. I would do small things I would do simple things. I would do a small OP practice. And I always like talking to patients. So I said, a decade of my life has gone into medical education. I'm not doing a further specialization. And that was 2010 May, and this is 2026 May. And thankfully, I have not been disappointed. So I welcome each of the residents who have chose family medicine as a choice or who ended up in family medicine out of no choice. Please welcome. You're one of the most important need of the country currently. And thankfully, from whatever I've listened, the policymakers are recognizing it slowly. Now it's up to you, the next generation, to take it to the next level. Now, without much wasting of time, is it possible for me to hear from some of you, what is family medicine to you? What have you understood as the core content of family medicine? And what have you identified as the identity of family medicine? You can put in the chat box.
Seeing
Okay.
person, seeing is whole person, identifying form.
Okay, so seeing whole person and understanding the person. Yes, anything else? For me, what family medicine I have understood is, always I tell this to our residents, I may be one of the faculty who speak very less about exams. Exam is just one day drama and that goes on with the pre-planned content. But your goal during your training is not just to pass exam. Passing exam and preparation for exam is just one aspect of your training. To me, family medicine is patient stories. And what I have learned the most for me as a person, what I have been able to teach our residents as faculty, and what has really helped me to grow as a person is these patient stories and patient narratives. And today I decided to share 3 stories of patients whom I saw in the last few weeks. So today's objectives, I told Dr. Vishnu, 30 minutes of webinar for a family medicine principal is a challenge because usually it is a lot of discussion with the residents, but that is fine. We'll try to understand where is the context of work of family medicine and what are the core principles of family medicine and why do we need to keep discussing about the core principles of family medicine? Medicine as such has its own discipline. And what is this outcome of patient-centered care? What is patient-centered care and what is the outcome of patient-centered care in improving health outcomes? So if you may have seen this slide on multiple presentations, discussions. If you look at it,
Ma'am, can I just intervene? Your
Yes.
slides are not moving and visible. It's still staying at the first introduction slide, ma'am.
I'm sorry, I'm moving it here.
Ma'am, can you just stop sharing Keynote? Is it so? I don't know.
I'm so sorry for this technical glitch. I will share it again. Sorry.
Yes.
Is my slide visible now?
Ecology of medical
Ma'am, can you just stop sharing Keynote? Is it so? When you continue to share, it is showing. I don't know why.
It says your screen sharing is paused. Are you able to see medical care?
Ma'am, you needn't go into the full slide mode show, ma'am. You can just proceed like this if it is a problem.
Then I may have to go back to. Is it moving or it's not moving?
No, it's not moving.
It's moving. Sorry for the delay. Trying to stop this. Shall I do it this way?
Yeah, you can do it this way, ma'am.
Now it's moving, right?
Yeah.
Yes.
Okay. So now this ecology of medical care, I'm sure many of the senior residents would have seen this. There is a particular reason why we discussing about family medicine principles. And the reason is, in the community, if you take 1,000 people, whichever community you're practicing, you're living, your family lives, of that, roughly 800 report symptoms. Of that, around 300 consider seeking medical care and only 200 visit a physician's office. Eventually, 21 visit a hospital outpatient clinic, 14 receive home health care, 13 visit an emergency department, of which 8 are hospitalized and only 1 is hospitalized in an academic medical center. Interestingly, our 4.5 years of medical school for we got some training, which is true. We got a basic MBBS degree for whatever evaluation it was done. That's true. But that has not fulfilled the objectives of caring a group of population in the community, which is where family medicine thrives. So to understand and come to a diagnosis for a patient who presents with illness in the community, you need to be trained in community-based care. And in community, not all patients present with biomedical illnesses. So there is a much bigger role as clinicians. The patient relationships, patient comes to see you as a person because they have known you over the years and they trust that you would have understood them as a person and you would help them the best way. And because it's community, it does not limit itself to a particular problem. Family medicine caters to the problem for what the patient presents for. And eventually the treatment happens to be a patient-centered, personalized goal. So this is something which you need to understand why we keep speaking about family medicine principles. So when so many patients from the community do not present to the hospital, or all the symptoms they present in the community need to be seen in the hospital, answer is not no. Their symptoms are true, but not always it has a biomedical background. It has other reasons that we need to explore as clinicians working in the community. Dr. Vishnu mentioned about some of the ONCA organizations, and of the many logos that I have come across, I always like this ONCA Europe logo. And the reason is, of the trunk is our core clinical skills. We are clinicians. We are skilled clinical experts, and communication with patients and with our team is a learned behavior, and we are expected to be very good communicators. And management of a practice depends on where we practice. So this trunk being a core discipline, and then these are the main branches which we will have to learn. And then there are these multiple branches, small branches. Is it really possible to learn all this within that 3 years? We will try to answer that question as we go along. But of the elective students, medical students who came to us, recently one student said they come for a 2-week elective in family medicine. When we asked the student, why did you choose to come to family medicine as an elective? The student said, I want to work in a secondary care hospital. And what I understood is family medicine can solve 80% of the problems. I didn't want to chase the remaining 20%. I want to equip myself in that 80%. Or in other words, 80% of the problems in the community are primary care, secondary problems that can be very well handled by a well-trained, equipped family physician. So the role of a family physician is in the community, which is very much part of the healthcare system. And the illness in the community is very different from the complaints and symptoms that we are usually exposed to in the hospital. So with that background introduction about where family medicine is, for physicians working in the community, it so happens that mind and body is mind and body. It's not either mind or body. So physical and mental diseases cannot be separated. I am sad today with diabetes, and that is something to be acknowledged. Managing diabetes and sending a sending to a counselor or to a psychiatrist for the other emotional challenges usually doesn't help. And that is not what patients come to you for. And when it comes to management of chronic diseases, where you will see patients over their lifetime, obviously you will come to know about the patient's personality as well as the context in which they live in. And in this background of understanding the physical, emotional, and mental context of the patient, early detection of disease and disability is very, very important. Now, in this situation, I want to just share one story, which was a very heavy story for me this evening. A 13-year-old came to our clinic about 2 days ago. We didn't see her for the last 3 years. All minor complaints is she's finished 8th standard. She's going to 9th standard now. 2 days ago, she was seen for amenorrhea, missed her periods this month. Basic investigation sent, hemoglobin TSH normal. And then today she came back for result. The resident who saw sent for pregnancy test, and pregnancy test happens to be positive. So that is where a family physician works. Would you send for a pregnancy test in an otherwise normal teenager whom you have known before? Or why did you choose to send pregnancy test for this 13-year-old who was accompanied by her mother who missed her periods? These are the questions that we need to learn to answer. So early detection of disease and disability, whenever there is minimal change from wherever they are, that needs to be picked up by the family physician. So as presented before both by Dr. Aishwarya and the huge family medicine academies, nationally, state-wise, it is an academic and clinical disease. It's not something thrown into the sea with no clinical or academic background. But interestingly, it is a generalist discipline. No one philosophy, organ system, age, gender, or institutional function defines family medicine. It is highly personal. It is dependent on the physicians and the patients who present to you. If you are going to a clinic completely in the community, the group of patients you see might be different if you happen to see another group of patients in a tertiary care hospital, or a group of patients are admitted in a district hospital. And family medicine is a contextualized discipline. It depends on the physicians who practice it. It depends on the patients who present for their care. And it also depends on the place where the family medicine center is located. Between the urban health center with an IP service to a community clinic where I go almost every week, to 2 paying clinics in the urban area of the city where we are, the practice is very different. The atmosphere is different, and I'm sure you will also be sharing the same thing. So in other words, if I am saying about the practices where I work, I am only saying about the practice where I work. If I have seen one family practice, I have seen one family practice. If you have seen 100 family practices, you have seen 100 family practices. And family medicine is a customized service. It depends on the local health policies, health systems, patients, and the physicians. Now comes to the actual session, teaching the principles of family medicine. I hope residents would have seen this book. This is the 4th edition of Dr. McVinney's textbook of family medicine. It's not a usual clinical medicine book with approach to headache, approach to breathlessness, approach to chest pain. The initial part of the book speaks about how a family physician should start thinking. And these are the 9 core principles that he advocates for. I would try to draw on our attention to 4 or 5 in this next 10 minutes. But interestingly, when our first batch of residents read this, they said, it all sounds philosophical, ma'am. What is the relevance of this in clinical practice? So true, it is difficult to understand and explain. And how do we facilitate the transfer to clinical practice? But that is what makes you a physician as a family physician, and not a diploma in medicine or diploma in pediatrics or diploma in obstetrics. Now, coming to the identity of family medicine, patient-centered care. Often I ask, we provide patient care. And then what is patient-centered care? We provide care for our patients and what do we actually mean by patient-centered care? So the initial part of it, wherein we get the biomedical information, the psychosocial information, that is something which we do routinely, which is expected of any clinician. But then there are the other parts which have to come along with this biomedical and psychosocial information. That is good communication skills. Are you able to communicate to the patient what the patient has? Are you able to understand the context of the patient, whether the patient is sad, patient is willing to listen to the information that you're going to share, willing to understand whatever news you're going to share? The communication skill is a very, very, very vital part of family medicine, because you will be communicating to patients all along in your career. Then comes the other parts, exploring patients' perspective of the illness and impact of illness on their life. Before going to the next slide, I want to hear from a few residents, what have you understood as disease and illness? Quick. Can some of you respond? What have you understood so far as the disease and illness? I'm not seeing any. It's all about how to study and whatever. Is disease and illness the same?
This is what we diagnose, and illness the status of patient from component.
Okay, disease is something to be diagnosed. Thank you, Dr. Alfie. Thank you for responding. You are the only person who seemed to be responding. And then what is illness?
The condition of patient, what the patient says, and what are things affecting them.
Disease is the signs and symptoms the patient explain or what doctors see in the patient. So there is more of disease definitions rather than illness. So the illness is something different. What is the perspective of patient's perspective of illness, and what is the impact of illness on their lives? I will just share a quick story again. This is a couple whom I saw last week. This is one of the clinic, which is a paid clinic. Well-educated, husband is an academic, wife is a housewife, came for some dizziness, some aches and pains, some back pain, no major medical issues. They have done all their blood tests to rule out the 7 masquerades of medicine, family medicine, thyroid, hemoglobin, sugars. And then I kept asking, who are you living with? They said, it's only both of us. Our daughter has gone to study last year. I said, how is it for you after your daughter left? They didn't give me much information, but then the pieces of puzzles didn't come together. You have somebody with dizziness and unwellness, and then you have all these blood tests. They're middle-aged, 40 to 50 years, and they look well, no obvious biomedical illness to be diagnosed. So then finally, I asked them, what is it for you after your daughter has left? Are you missing her? And that is when the husband said, ma'am, to speak the truth, my wife wanted her to be a doctor. But now it so ended up that she could not get through her entrance examination. She has joined another course. And when this consultation happened, the re-NEET was not announced. So the one NEET which happened this year was supposedly easy. So since then, my wife feels, should we have made her to write the exam again? And that is when all her symptoms of unwellness starts. So the dizziness part, the unwellness part, not eating well part, it has an organic component, which is always our first area to rule out with the red flags. And then once these are ruled out, then you see what exactly is causing this illness. And then I had to do a shared decision making. I told them, I'm not going to be doing any blood test, but it so happened the NEET re-exam is announced and you still want your doctor to appear. They said, definitely not. through this, there was a shared clinician relationship. So illness is something at the end of this class, I expect, I request these family medicine residents to go back and ask your patients when things are not fitting together, what is the illness of the symptom which they are presenting with? So on the left side is what you are usually taught. You do it quick. And then disease is what, as many of you shared, malfunctioning or maladaptation of biological or pathophysiological process. Now comes the patient-centered history. It comes in multiple mnemonics. It is ICE, it is 5, it is PRICE, there are multiple mnemonics to this, but basically you want to know what is patient's understanding of their condition and try to understand their context of family, work, and social context. So illness is primarily what represents personal, interpersonal, or cultural reactions to disease or discomfort. If I have to say my thing, maybe 10 years ago or so, if they had asked me to do a webinar, I would have been sweating over the years, sweating with headache. Now, did that headache have an organic cause? Not so far. But today I have learned to do things. So a symptom, always try to explore the illness. And in some of the groups that the faculty group, they say, residents don't understand what is ideas, concerns, and expectations. Keep it as a simple checklist. Idea, what do you think is causing your disease? Concern, what is the most important concern for you right now? Expectation, what do you expect from this hospital visit today? And you will be surprised to hear what are the responses that you hear from patients. And based on that, more than likely, your management decisions will change, or it will open doors to help form shared decision making. My time is getting over, but I will try to go through the remaining slides. So this is basically the illustration of the disease, what the doctor perceives as the cause of the possible symptom. But then there is another side to it. What does the patient perceive the cause of their symptom? And how an illness affects people's role in society. And that is what they come out as sickness. Now, do all patients with disease have illness? How many patients you would have seen with asymptomatic hypertension, asymptomatic diabetes? They are well otherwise. They are going about their daily activities. They continue to work. Their life is well. That is disease with the illness. On the other hand, there is multiple symptoms, medically explained symptoms without disease. Those are the worried well. Now, when I make this statement between disease without illness and illness without disease, please be very clear. We are not trying to be judgmental. We are trying to help understand by ourselves as well as to the patient that their symptoms are not false, yet their symptoms does not have an organic cause. So the symptoms may not need the next level of investigations. It will need additional form of treatment. So what are the benefits of patient-centered care? Benefits for the patient goes back with better satisfaction. There is improved health outcomes. Similarly for the clinician. Till to date, 15 years into academic practice, there is always something to learn for me. I'm not telling about just the medical aspects of it. And there is always something for me to learn as a person, as a parent, as a teacher. And this stories is what keeps me going. More than important, during the first session by Dr. Aishwarya, the healthcare costs in our country, which is all out of payment pocket, please try to understand what the patient presents for. And if you can understand that, then you can improve your adherence to treatment, improve the overall quality of care, lesser hospitalization, and shorter hospital stay. I am going to skip some slides. Now, this is what I just discussed about the patient-centered care. 4 steps, if you want to remember it just as a checklist, you explore what is health important, what is health to them, what is disease to them, what is the illness experience. And now come back to and see if all has an overlapping component. Sometimes the illness will not have an overlapping disease component. And this forms the person, and person has a proximal context, which is their immediate family, workplace, And then they have a distal context, which is their neighborhood community and so on. When you try to understand these two components, you will be able to understand what are the patient's problems, what is the goal of care for the patient, what is your role as a physician, and how can you enable the role of a patient and family for that given condition. And finally, when you do this, your relationship with the patient is a lifelong lasting relationship. It is something like a family member. You would recognize them and they would recognize you. So quickly, specialists see different persons with specific skill, with specific symptoms and diseases. Family physician sees a gastric complaint, a skin problem, and a gynecologist in the same person. So that gives you a lot more privilege to understand the person, as well as to, over a period of time, form into relationship with them. Now, I have 3 more slides to discuss. One is contextualized care. As I explained the context of the patient, please be aware and cognizant of where we practice. Are we aware of our patients from places of social, economic, or geographical marginalization? We had a fellowship student a while ago who asked, family medicine is probably only for poor patients because you provide subsidized care. We took a while to explain and then to make him understand family medicine principles are the same, whether it is when we are working with a marginalized community or when we are working with a community with well-resourced community. The principles are the same, but the options available to them may be different. And are we understanding to the concerns of those in greatest need? That is something we need to know. That is why we ask that question, ideas, concerns, and expectations. Are we willing to understand the concerns, understand their expectations, and come to a shared relationship with patients? So, with this being the context of the care, continuity of care. 15 years now, yes, I have seen patients, their medical problems over their middle age, 50 plus 60 years, then their children delivering, then the newborn care of their grandchildren, then newborn having minor problems. So these clinical encounters with a patient can be over a period of time. But always over a period of time, you get to coordinate for them. You always develop a relationship. There is a personal emotional connect, a trust develops, and the quality of care improves. To go back to how we can contribute to the healthcare system, we will be able to decrease the cost, number of hospitalization, improve patient and physician satisfaction, and continuity of care is most satisfying in the career of a family physician. Whole comprehensive care. Now, comprehensive care, it is across a lifetime, or it is different age groups, adult, pediatric, maternity, elderly, palliative care, or it is in different settings, inpatient, outpatient, community, and home visits, preventive and promotive. Now, when I mention this, do every family physician get to do this? Do every family physician have to do this? It depends. It is a customized service. It is a contextualized service. It is a team-based care, or it's a solo practice. In principle, comprehensive care is one part. When a patient comes to you with URI with a BMI of 30, you don't stop there with BMI. You don't stop there with URI. You go back to ask the patient to come back for this BMI screening for risk, screening for non-communicable diseases related to high BMI, and so on and so forth. So that is comprehensive care. And coordination of care. This, I would say, is probably one of the most challenging, because speaking to multiple departments, multiple social networking agencies, discussing cost with the patient, discussing cost with the family, and navigating between the community where the patient is from and to the very complex tertiary care system. If we don't do it, if we are not doing it, if we don't want to do it, nobody else is going to do it. It will take a lot of your time. If I have to coordinate care for a patient, I know it's going to be 30 minutes. But that is something which will reward the patient, because if done poorly, patients suffer. It's not only phone calls and multiple messages. It's about discussing the cost of this test, Do you have to do this test now? And review of the multiple consultations they have done, what referrals you want to do further, what other consultations. So coordination of care is something which I certainly believe only we do. Whole person care, one of you believe. Between comprehensive care and whole person care, there is some overlap. Comprehensive care is probably different settings of the healthcare system. Whole person care is whatever patient concern of their multiple symptoms, you go back to their whole person care with biomedical, psychological, social, family, and community. Now, finally, coming to the family medicine principles, of what Dr. McWhinney's 9 principles, I have included the 7 C's, which is first contact, continuity, comprehensiveness, coordination. Now, can we do all of this for an entire population? Family medicine is a geographically defined discipline in specific communities. So going back to our communities is very, very important. It is a very complex discipline. More often than not, it's not a straightforward answer, and it is a contextual discipline. So to residents, we walk the complex journey of health and illness with each patient. And with that, I will bring my presentation to an end. These are the references. These are all available online. And particularly this BMJ Family Medicine Community Health has 12 reflections on storylines of family medicine. And most of the illustrations that I had taken are from that. And then Dr. McWhinney has this Foundations of Family Medicine. And as you all grow into the next level of academics, you are to reflections and patient stories. So with I will end the session. The take-home message is patient-centered. What is the age of this patient? What is the context of this patient? What is the concern? What is the expectation? What is the goal of treatment for this patient? What is my role as a family physician? And what is going to be the decision for the patient that I have taken in discussion with the patient? So I am not sure that if I've already crossed 10 minutes, so maybe we will go over to the next presentation and have questions if possible towards the end. Thanks to the Spice Route movement for this session.
Thank you, ma'am. We are so happy to have you here for today. So thanks a lot from Spice Route Kerala chapter and the entire Spice Route team. So let's move to the next session. This is another important session considering family medicine as a specialty. Let me welcome Dr. Hemavati ma'am, Associate Professor, Department of Family Medicine, St. John's Medical College, Bengaluru, for this session. Welcoming you, ma'am.
Thank you very much. I was just trying to share my PPT. Thank you, Dr. Sajita. That was a very good presentation, and you have made my job easy, and you have set the context for this presentation. And thank you, Dr. Vishnu, and your team for organizing this very wonderful, much needed, and impactful session. Just give me. I'll make sure that I'll finish in 15-20 minutes because Dr. Sajita has covered most of the things. I need to summarize and give the.
Any issues, ma'am?
I'm sorry for this. I'm not able to share the. I think.
Ma'am, do you want me to share from my side?
Is it seen now?
Yes, it's coming. Yeah, it's coming. It's fine.
Is the slide?
Yes.
It's fine, no?
Yes,
Okay.
ma'am. Yes, ma'am. It's fine.
Dr. Saji, yeah, I'll continue. Dr. Sajita has spoken a lot about patient-centered care. So this three-stage assessment is one of the clinical tool to practice patient-centered care. So I'll just spend few minutes on discussing why are we doing this. Okay, normally I like to do a lot of interaction, but since we have time constraint, I'll just try to explain why we need and how to implement this, taking few case scenarios. So if you look at our traditional. So in this method, if you look at the method, the entire method is designed to we as a primary care physician will encounter a lot of practicing in the community. We will be looking at the diseases in their very early stage and not yet taken their full, come with very vague symptoms, or you are not able to arrive at a particular diagnosis with that symptom. So we'll see lot of undifferentiated problem and lot of with depression, COPD with depression, and there is lot of this biopsychosocial complexities in every is one more important thing is the relationship between the doctor and the patient is very unique. It's a continuous relationship which is very intense and personal actually. And if you look at the disease morbidity profile, we see lot of high incidence morbidity. That is, we will be diagnosing lot of diabetes, hypertension, making, detecting even cancer. So we will be diagnosing many things where patient needs lot of hand holding and support. So with this kind of morbidity, what we are looking in is that we should ask ourselves again and again, does our traditional method can do justice for our morbidity profile? I want to bring in one more context here. See, if you look at any individual for yourself, if you are going through any illness, along with the disease or the symptoms illness, as an individual we go through fear, worry, and we have our own explanation. So patient will have their own explanation of what is happening with them, and these symptoms would have impacted their life. They would have lost some functioning, they would have stopped doing something, and they will come to you with a certain expectation. Some people will expect cure, some people just want their this test to be done. A day patient might ask, I just want a CT scan to make sure that I don't have any other disease. So they'll come with different kind of expectation. And as a primary care physician, you all know, and with the last presentation, we understand that our basic character, any general practitioner should have empathy towards their patient, should practice, and uh, should be our nature empathy. So if you want to be empathic, then we need to explore all this aspect, psychological aspect of the patient. And there is a need. If you look at our traditional method, the care model is usually directive approach, where doctor is telling the patient what to do. This is the diagnosis I've made. This is the treatment you take. There is no scope for exploring this individual aspect, psychological aspect. But the shift that has to happen in general practice is moving from directive approach to a partnership approach. So what is this partnership approach or a shared decision making? You heard the term, no, shared decision making. See, in this partnership approach in general practice, we always think you're not the only expert here. Here there are two experts. You as a physician who is an expert of medical knowledge, you know about the disease, their prognosis, what needs to be done. And patient is the expert of his experiences, his experience of illness, his social circumstances, his habits, his values and preferences. So these two experts, they share information and commit to negotiate and arrive at a plan. So that is called as partnership approach. And here, with this partnership approach, we will be able to capture biopsychosocial aspect of the disease comprehensively, and we will be able to arrive at a plan which is acceptable to the patient and their ecosystem. That is the main purpose. And this model of care, no, biopsychosocial model of care, can be achieved using this technique, three-stage assessment, clinical tool. So this three-stage assessment clinical tool was first coined by McMinnis. You will hear about it, you will read about this in his textbook. But later, this was developed by a few physicians, and they gave a nice framework for this, how to actually practice and implement this. So we'll go through this three-stage assessment now. As the name itself indicates, it has three steps. First is clinical assessment, which tells us what is biological. Uh, can you can you not hear?
Yes, ma'am, you are audible.
Is it fine? No, it's fine.
Yes, ma'am. Yes, ma'am.
Yeah. So in the first stage, it is very simple, where we are doing our clinical assessment. That is our normal history, physical examination, investigation, and making a diagnosis, which is a biological diagnosis. And the second stage is the individual assessment, where we explore more about the patient. So we ask, after taking history, you ask questions like, do you have any other concerns? What do you think is happening? And what are you expecting me to do today? These are the questions you can put it across, and these are very well appreciated by patients. Even if you are saying you're seeing a patient from a very remote places, no, don't hesitate to ask these questions. I especially ask them, what do you think is happening with you? Especially when they are coming with very vague symptoms, then they will narrate their the other part of the history. So these are very simple questions, and always ask these questions, and don't think you are asking something non-medical, and patient will think that what is this doctor asking. So be very clear about the need for these kind of questions. So the third step is contextual assessment. So in this contextual assessment, basically what we are trying to do is we are exploring the family dynamics, which is their first, uh, you know, uh, 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 the closest circle, and their micro ecosystem, and their financial stability, about their employment and others support system. The basic idea here is actually we are trying to see whether the plan we are making is acceptable and feasible for him, for the patient, and the specific environment he is in. So for this contextual care, there are many tools you can use. You can use family genograms. If you want, we can share more materials on this. There are articles on family genogram, how to draw. This is like 3 family trees, but in much more detail. Their interpersonal relationship, any loss in the family, how is the relationship between them. All these things can be depicted in the family genogram. Or you can go for family apgar if you feel there is the issue here is the family, then you can use family apgas, like which tells you the tools for actually this is a tool for measuring family function and the support system in the family. And the other important commonly used tool is echo mapping. This is, I'll show you few echo mapping. This is a visual presentation of the patient's broader social environment, like their work and hobbies and communities and all these things. So basically, this ecosystem and contextual understanding will relieve what is the support system of the patient, or there are any hidden barriers to the treatment adherence. Okay, so with this background, you understood, no, stage 1, stage 2, and stage 3. Stage 1 is clinical method where we do our normal traditional thing. Second is individual assessment where we ask questions like what is your ideas, expectations, and concerns. And third is contextual care where we use these tools to understand the uh, context and social background of the patient. So we'll just go through few scenarios just to see how this clinical method can help us to achieve this patient centered care basically. So this is a 28-year-old patient who came to our clinic with the complaints of generalized weakness and breathlessness. He looked very pale at the first glance itself, and he was carrying the report with him, which said hemoglobin of 5 grams, total count of 3,200, and platelet count was also little less. There was no other report. And on examination, he was completely, there was no organomegaly, lymph nodes, nothing was there except for pallor, and he was a vegetarian. So, with this history and traditional clinical approach, what would we normally do? We'll ask him to get admitted. We'll carry a battery of investigation of ultrasound, OZ, everything can happen in any secondary or tertiary care, and we might receive a blood transfusion, and we will go back with a diagnosis. That is normally happens. So let us take more details about his personality and the social circumstances he lives in. So this man worked as a delivery boy in a mess in a university. So his job was to deliver food to the rooms of the students so he had to walk a lot, climb upstairs. So with this breathlessness and hemoglobin of 5, he was not able to do this job, and he was very scared of losing his job, and he also thought he had heart problems, and he wondered that he would need big treatment. So and he lived with his aged parents. The other 2 siblings were married and living separately, so he was the only breadwinner of the family. And his greatest support was his employer actually, so who supported him and understood. He felt that he was a great support for him. So with this background, of understanding his context, like he cannot afford much thing, and there was already loss of function, and he did not choose to get admitted, and he was very scared of getting blood transfusions and a big very invasive things to be done with him. So he was very clear about it. So with this personal preference and his background, and we negotiated that, okay, since he's not in failure and it looks obviously clinically vitamin B12 deficiency, we said we'll take a chance. You need few tests. We will not order too many tests. And since his employer was a big support, we spoke to him over phone and we said, this is something looking very simple. Just give him lighter job for few weeks, for a month, and by then he will recover. And he asked his employer to support for few investigations. So we did very basic investigations, like very much required peripheral smear, B12 level, and these things. And B12 deficiency was established, and he was treated on a OPD basis with parenteral therapy, and he was compliant for his treatment, and he recovered. So these are the ways that it makes a lot of difference to your approach. And I had seen him some 7 8 years back, until even today he is my patient. So when you adopt these kind of approach, they become your lifelong they would not go to see any other doctor. They would prefer you. Was a 42-year-old female lady who was very worried about her symptom, and her request was, she was very clear about her expectation. She wanted to explore why this tiredness, and she was willing to do all kinds of tests, though they should not come for a very well-off family. Her only morbidity was hypothyroidism. Again, when we looked her context, she was in a very complex situation. She had lost her husband recently, and was in a very big financial crisis, and had a loan of 5 6 lakhs. Her elder daughter had to get married, and her marriage was fixed. To support her, her first son quit studies and supported taking a job. Her third son was studying and thinking of quitting a job, considering the family. They had a court case. So she was in a very distressful situation, and her PHQ score was very, very high. So, with this background, her approach, though, uh, uh, our approach was, we reassured that her biologically there is not much problem, but it looks like a depression. And to reassure, age related simple blood test we gave her, and we called for a family conference to reassure things and to be uh, to to see what is the way forward. So these are these kind of approach will make it it will satisfy. This is one scenario where you can say patient was very satisfied, and was reassured to the best, I would say. And this is very quickly, this is another scenario where he kept coming to our OPD with a uncontrolled BP. I kept increasing his medication.
Your screen sharing stopped. Hema ma'am. Ma'am, are you there? Hello. I think she got.
No, ma'am is there.
I hope you have understood
Ma'am, your voice is breaking.
the need for these techniques, how to use this. So, is it okay now? Uh, is it okay, Vishnu?
Yeah,
Or
now
is it still breaking? It's okay. I just have two more slides, that's all. I'm just trying to summarize. So it does take time, 15-20 minutes. It might 15 minutes you might take it. So you need not do this method for all your patients, but definitely adopt this clinical methods when where you see lot of undifferentiated symptoms in a patient. The patient has a chronic disease. In at least one of the clinical encounter you do this, or whenever you diagnose a major illness, or patients having lot of high risk behaviors, mental illness, depression, anxiety, and definitely geriatric patients. At least in these scenarios, it is one of the best tools to use. And what difference does it make? We went through that. It helps us to achieve adherence, and it helps us to solve the insoluble problems. If you're seeing somebody's diabetes is not getting under control, hypertension is not getting control, then this is the clinical method you should adopt and try. And it is a system. It improves the systemic efficiency. It makes your approach cost effective, and it brings significant satisfaction for both the doctor and the patient. So with this, I just want to end with this message. Person is the center of care in family medicine. I think this technique will help you to achieve this. Uh, Thank you all, and thank you, Spice Root, for giving me this opportunity.
Thank you, ma'am. Thank you for having me here for this session. It's our privilege to have you for today's this program. So once again, thanking you from the side of Spice Road Kerala as well as the Spice Road chapter. So let's move to the next session, that is curriculum and exam overview and academic aids by a person who don't need much introduction, Dr. Rashmi S. Kaimal. Ma'am is currently the head of the Department of Family Medicine, Lourdes Hospital, Kochi, and the National General Secretary, Academy of Family Physicians of India. Welcoming you, ma'am.
Ma'am, you are on mute.
Am I audible now? And was the screen I had shared
Yes,
indicating?
yes. Screen, please put
Yeah.
in the slideshow now. Screen is visible.
Cannot see. Oh my God.
Your screen is there, ma'am, but just that you have to put in the slideshow mode.
Yeah, I'll put it in the slide. Yeah. I think time is running short, and all PGs are bored of hearing so many things about family medicine. So I'll just rush through because this is very important for you for coming out of these 3 years post graduation. Whatever is important for you after that for practice has been already covered in the 2 previous sessions very beautifully by Dr. Sajida and Dr. Hema. So this is just to tide over the 3 years of postgraduate training, and I've seen in the the chat box already I can see the what do you say, unrest, or people are unhappy about having taken family medicine. It seems there is some negative thoughts also about that. So first of all, this is a very new specialty in the sense acceptance in the community is very new. So it has been an age-old specialty, but the acceptance is very new, and so we'll have to tide over so many hurdles before we compare ourselves to other training, other PGs, or what happens in other departments. So with that words, I'm not giving all the curriculum in this 20 to 30 minutes. I'll cut short. Vishnu will kill me if I go beyond 20 minutes. So I'll try. So DNB curriculum is divided into, it's actually like a modular training. So 6 modules, which has family practice for 6 months, general medicine and allied specialties for 9 months. What are the allied specialties? Psychiatry, dermatology, and all those things. So general surgery and allied specialties for another 6 months, which includes general surgery, anesthesiology, ENT, ophthalm, and orthopedics. Then pediatrics for another 6 months, which includes pediatrics and neonatology also. Obstetrics and gynecology for 6 months. Emergency and trauma for 1 month, and another 2 months of elective training, depending on the institution where you are training. Some institutions might be having PMR, you can get trained in that. Some might be having palliative care departments, you can get trained there. Some in geriatrics, so like that. So, and family practice 6 months. So diploma has a bit compressed version of the DNB curriculum. I'm not detailing it, but I think if you go through, I will not ask this question because all of you will be embarrassed to answer it. How many of you have gone through your curriculum in the site website, National Board site, before starting the course? Have you all gone through what you are expected to be doing in these 3 years, what you are expected to learn in each rotation, what is the purpose of each rotation, how many months each rotation is there? I will not even ask the final year because even they would not have gone through the curriculum. So all this is on the net. You can go through the diploma curriculum, DNB curriculum, MD curriculum, everything. And then let me come to the, I'll tell that later. Let me come to the MD curriculum by NMC. Again, it's all these are covered, but a little bit of difference will be there. 2 months, 3 months, 6 months, a slight variation will be there because these are different people setting the curriculum and setting the syllabus. So a slight change here and there will be there, but the ultimate aim is to get you trained in all the broad areas which will equip you to have a broader view of patients, to function as a generalist, and whatever the previous speakers told about the principles of family medicine. So all these things you should be equipped at the end of all these 3 years. And MD in AIMS, which was earlier community and family medicine, now the new AIMS have started MD family medicine. So again, a slight variation in the postings is there. So these are the links. You can, I thought if I have time, I'll just click the links, but you can all get it on the net. So now what are these things? Specific learning objectives. What are SLOs? Curriculum is a thing. I mean, it's a document. And whenever you go to any posting, any rotation, you should know what to do with that posting. What am I supposed to learn in that rotation? That is the knowledge and skills to be acquired during each rotation. There is a comprehensive and exhaustive list designed by the NB, NMC, AIMS curriculum. Everywhere there is a comprehensive list. It's too exhaustive. Still, you are at a loss as to what you are expected to know. So when you go for each posting, you have to be familiar with the SLOs for each area. And also you have to know your institution also. You have to know about the work done by all specialty departments of your institution, because it varies from, the training varies from institution to institution. Ground reality at one institution is different from that in another institution. So you have to know about what is happening what you are expected to learn, and at the same time what is happening in your institution in each department. So expectations when you join for the course on the first day is that everyone knows what family medicine is, and all SLOs will be implemented, and there will be a supervised learning of procedural skills, lot of academics. I get queries from students who get ranks in NEET PG entrance asking, can we, do we have class every day? What textbooks do we follow? What these procedures, they'll give a list. Are all these procedures being taught? All those things. So and also you think that there will be an assessment after each area and guidance on how to improve. These are your expectations when you join for this course. But the reality is that faculty in other specialties have no idea about family medicine. That strikes you first. And then you know that it is more of, especially in the national board institutions, might not be the same in MD institutions, because basically they are there. These are teaching institutes, but DNB or diploma happens in institutions which are not primarily teaching institutions. So there is more of clerical work and cheap labor involved, especially in the case of family medicine, because you'll be shunted to department to department, shunted from department to department. No academics as expected. And people will ask, what are SLOs? What do you mean by SLOs? There is only three FAT conducted by National Board and one final exam. There is no assessment at the end of each posting. So the first year FAT, formative assessment test. First year there will be a theory exam conducted at your institution. Second year, it will be conducted, National Board will conduct a centralized theory and practical exam. Third year, it will be again at your institution, a theory and practical exam. The MD pattern is different for the NMC and for the AIMS curriculum. AIMS, the formative assessment and summative assessment has a different pattern that is followed. Now, rather than complaining about our facilities or what others don't know about us, when life gives you lemons, what do? You make lemonade out of it. You try to make the best outcome of your training. So first thing is, you should know your strengths and weaknesses. When you go to a posting, when you start learning a new thing, when you approach a new patient, you should know what is your strength. Where is your strength? Are you good at procedures? Are you good at communication? Are you poor at communication? Do you get panicked when in an emergency situation? So that things you should know what is your strength and weaknesses. You should build upon your strength and try to overcome your weaknesses. So that's how you improve, you get out the best out of your training. Explore your opportunities. It is not that you're 3 months posted in medicine, you will completely focus on medicine. No, somewhere else there should be some opportunity of seeing some other patient. You can always go and see that patient because you're a family medicine resident. It's not limited to your current 2 months or 3 months posting. So always grab your opportunities and try doing things, try seeing patients. Be in the OP, wards, ICUs, emergency, labor room, wherever you're posted. Be there. One of my residents, I always tell this, I think I've been repeating this every year in the Spice Route session. Residents asked our pediatrics HOD on the first day of posting, sir, what are the books that we have to learn? He said, no, the books, patients are your books. Okay, so you be there, be with the patients, be with the people and learn from them. Those are the best reference material that you can get. It is not daily classes, listening to somebody is presenting a PPT and you're making notes. That is not what postgraduate training is about. At the end of MBBS, you are supposed to take a proper history examination and arrive at a diagnosis. But at the end of PG, you are supposed to manage people. You are supposed to heal people or cure people. You are supposed to practice, go out and practice. You have to be a safe doctor, a good doctor. So for that, you have to be with patients rather than being with books. And always be open to learn, ask or clear doubts. It is not like, what will they think if I ask this? if you knew everything, you need not have done post-graduation, isn't it? So your time, these 3 years are the best time that you can utilize to clear all your practical doubts, and so that you can go out and practice with confidence. Always interact between colleagues, seniors, residents from other specialities, and other consultants everywhere. Interact wherever possible. You interact with other people about what are the patients they see, how they approach, and then you can formulate in your mind what is wrong in that, or what is right in that. Study discussion groups will help you. Seminars, lectures, case presentations, journal clubs. Have anybody heard of journal clubs? I was requested by the organizers to tell more about journal clubs. What is the purpose of journal club? Journal club is to prime you how to conduct research, how to draw evidence from already published articles. So conduct journal clubs, conduct case presentations, seminars, lectures. The consultants may not be willing even then, or why I'm using the word consultant is because I'm working in a DNB institution. The situation, I always reiterate that situation in medical colleges might be different, because they are not primed to teaching. So they might not come on their own to give you classes. So you can conduct among yourselves. There can be study groups, discussion groups, and all those things. And you present among yourselves and discuss the patients that you see daily. During specialty posting, consider every patient you see as a learning opportunity. Try to achieve as many learning objectives as possible, considering the limitations of your training institution. Understand what is important for your practice as a family physician, not as a system specialist. You might be learning during pediatrics, you might be learning these things are being managed, but you have to think yourself as a family physician, what difference can I make in this treatment? Is this the right approach? How should I change this approach? That you can learn by knowing the principles of family medicine, and all the how to assess a patient as a whole person, like Dr. Hema mentioned in the 3-stage assessment and all those things. So you understand what is important for your practice as a family physician. Acquire procedural skills as much as possible, but doing procedures or seeing complex cases are not the ultimate aim of any of family medicine postgraduate training. Integrate the principles and concepts of family medicine to the clinical knowledge you acquire from the other areas. Like, for example, you go to general medicine, you see a type 2 diabetes mellitus patient. You are not concerned just about managing what all OADs, oral anti-diabetic drugs, will you give, what all when will you start insulin. That's not the purpose. That is there. Plus you have to explore what other complications this person can have, how is his context affecting this, and vice versa. So wherever you go, what is his family doing about this, and what are the problems that because of his diabetes his family is having. If he is elderly, what is the risk for his children to have diabetes? So all these things should go on in your mind as a family medicine training. It is not that people will teach you and you complain. No, you have to learn by yourself. So this is just an example of some of the patients that you see, some of the case scenarios that you see, and you can always have a comprehensive approach to any of these patients. Okay, I'm not detailing each one. Other requirements for post-graduation, of course, a logbook, which I find that people write it on the eve of the family medicine practical exam. No, you kindly write it, or enter whatever you have done or whatever you have studied whenever you do that. That gives you also a confidence, and later when you go back, you can know, yeah, I did this that day. So what was different from, suppose you did a IV cannulation in a child 1 month back, and now you're doing it again. You can always go back, what was the patient that I did IV cannulation that day, and how different is this patient? What is the indication in this patient? That is how you learn for post-graduation. Thesis, of course, for DNB and MD, but not for diploma. You have to have a research question in your mind. If anything can be a research, and kindly choose relevant things to primary care and family medicine. I know it is time to submit your protocols now. So I hope all of you have chosen topics that are relevant to your specialty. Now, clinical audits is a very good way to learn what is working and what is not working and how you can improve in the hospital. Attending conferences, of course, that is a must, because only then you see birds of the same feather and you can interact and you know how things are happening in other parts of the state or other parts of the country. You have to present your research articles or case presentations in the state and national conferences, publish your research studies or publish your case reports. All these things you can do. There is plenty of opportunity, plenty of things that you can do during your post graduation, which will help you not to complain much. You can keep yourself busy by doing all these things. Focus on the positives that you can do. Okay, now these are some of the books. Murtag's textbook is there. There is another practice tips. Oxford Handbook of General Practice is there. Textbook of Family Medicine by McWhinney. Textbook of Family Medicine by Reichel. All other clinical textbooks and whatever books you have already learned in your undergraduate curriculum for each subspecialty, all those can be referred. Journals, there is an Indian journal that is the Journal of Family Medicine and Primary Care, Australian Family Physician, Annals of Family Medicine. There is quite a list of, you can see in your curriculum itself, the journals have been given. So answer to the frequently asked questions, which textbook should I read for each area? You have to first see the patients. Then you have to read standard textbooks, not guidebooks or notes of seniors. You can always refer that, but kindly read standard textbooks. I can see Vishnu smiling. And also you can read the latest updates. Nowadays, it's not like the time when I did a PG. Everything is on your fingertips. You can always, but I had a student who referred to ChatGPT for answers. Kindly don't do that. Read standard textbooks and then refer recent updates on the net. With that, you can slowly improve your knowledge like that. How much to learn in depth regarding each area? That is where the curriculum, the SLOs have been given very clearly in the curriculum documents of each, DNB or diploma or MD. Go through that and then you will get an idea of how much should I learn in each. Today, a student asked me, Madam, why should we know about the surgeries for stress incontinence in a female or surgeries for prolapse? We are not going to do that. You are not going to do that, but you should know that what are the surgeries, because a patient, your patient who's under your care for other things might be coming with a stress incontinence and prolapse of uterus, and you try medical management. You should know when to refer to the gynecologist for a surgical management. You should be able to counsel this patient about the advantages and the contraindications or the adverse effects of the surgery, the complications of the surgery. You should be able to guide the patient when the patient comes back to you. For all these, you should know what surgical options are there. That is why we are learning. So the depth is, if you understand what you're supposed to do, you will know how much depth you have to learn. You don't need to know the steps of TVT or the steps of vaginal hysterectomy, but you definitely need to know when to refer to a gynecologist for vaginal hysterectomy. Okay. So is exam-oriented learning and practice-oriented learning possible simultaneously? Of course, it is possible simultaneously. There is nothing like you learn separately for exam, you learn separately for practice. No. Some areas you have to specifically, some time you have to specifically devote for exam. Otherwise, your ultimate aim is for practice. After this was a question that somebody asked in a conference. A student stood up and asked this question. After rotation in a specialty, when I go to the next rotation, I forget the skills or knowledge acquired in the previous rotation. How can I overcome this? I do not know how to answer this question in one or two sentences, but I can tell you that the whole hospital is yours. Unlike for the other specialties, the whole hospital is yours. You can always go back and brush up your knowledge. Your colleagues will be in other departments. Your seniors will be in other departments. You can always discuss with them. And whenever you come together, you can discuss what is happening in the other postings, what is happening in the other rotations. Always keep learning every day. It is not limited to one posting that you learn only, that you learn medicine only during the 3 months. No, it's not like that. And family medicine is not a mixture of all these specialties. It is much more than that. The concept of the principles also should come into play. So if you apply the principles, this question will not come in your mind. Now, do I have time to go to the next thing, that is about the exam overview also?
Yes, ma'am.
Vishnu,
Yes.
Suchitra,
Yes, ma'am.
5 minutes. Yeah.
Yes,
So
ma'am. Yes,
yeah.
ma'am.
So yeah. So the exam overview. Always remember, it's just an exam. Exam happens every 6 months. So if you don't clear this time, you have an exam another 6 months, and ultimately you will clear someday or the other. So don't worry, it's just an exam. It's not the end of life. So theory exam and practical exam will be there at the end of the 3 years. There are 4 papers for DNB and MD, but diploma has 3 papers. Kindly go through your curriculum to know what are the 3 papers. There are students who ask on the eve of the exam as to what is paper 1, what is paper 2, what is paper 3. No, that should not be the way. You should know, you should be well versed with what is expected to be what questions will be expected in each paper. And practical, DNB and MD will have OSCE cases, ward rounds, Viva, and diploma has cases and Viva. The pattern, I think, before every exam, SpiceRoute conducts a practical exam orientation session, and I think also webinar session also. So I think most of you are first years, and if whatever I tell about exams now in detail will go over your head. So just few examples about some of the questions that come, and kindly, if any of my previous students are here, please forgive me for quoting your examples. So when to start preparation? From the day 1 of PG, or from second year, or from final year, or all duties and clinical work have reduced, then I'll start study, or after the thesis work is done, or from announcement of exam date, or from last 2 to 4 weeks before exam. When do you start study? Studying is a continuous process starting from the day you join PG. That does not mean that you start reading books from the first day. As I said, it is all seeing patients from the first day, and everything will help you in your exam. Okay. So do you make notes, or do you read and highlight in textbooks? Do you prefer individual preparation or group study? Early morning, late night, whenever possible? Home, hostel room, library, anywhere? So these are all your personal choices. There is nothing standard. You are all above the age of 22 or 23. So you all will have your own ways of learning. You're not primary school students to develop a new way of learning, or developing a new way of studying. If you have made notes till now and studied, continue doing that. If you have not made notes in your life till now, don't start preparing notes now and then compare yourself with your colleagues and, oh, that person prepares notes but I cannot prepare notes. That person is reading textbook but I cannot memorize the textbooks. I am not of the same wavelength of others for group study. See, whatever suits you till now will suit you for this next 3 years also. So don't change your pattern now. So how the study pattern has helped you to overcome the MBBS hurdle of MBBS, that will surely help you in your PG also. As I said before, what to study, seniors notes, that is the last thing. Textbooks, I already mentioned. All topics from all areas A to Z. No, you should know what you should focus on, because you should know what your practice is about and what family medicine is about. Then you will know what to learn in each area. That is where the SLOs and your concepts of family medicine and your practice area. There was one student of mine who went an extra 2 months to gynecology, because she came from a place where there are many women who prefer to come to female doctors. So she said, I want to have an extra 2 months evening. I'll go to the gynec OP and sit and learn. So that is how you learn. You learn depending on where you're going to practice also. And areas covered in Vishnu has a good collection of previous question papers. And anything that comes out of it, people will start blaming Vishnu, saying that this was not said before. So previous question papers you should refer, but that is not the that is not the only thing that you have to learn. You can go through previous question papers to know what will come in exams. Especially conferences, CMEs, institutional academic presentations will have information that you can compile and you can use for your exams. So, do you know your exam pattern? As I said before, you should know your exam pattern, DNB, MD, diploma, how many papers are there, what are the areas covered in each paper, how many marks, weightage of marks from different areas. For that, you have to go through the previous question papers. For that, essays, short answers, how to frame applied clinical questions, how much will come, what is a pure theory that is asked. All those things you have to go through the previous question papers or discuss with your seniors and get used to those things. So know the best mode of learning for you. Practice for theory exam, practice writing exams. That is the best thing that you can do. You can take a previous question paper, start writing it in 3 hours, and then you can judge yourself. There you need not be a faculty to guide you. You are all adults. You can go through what you have written, go through the textbooks and know what mistakes you have made, or you can ask a senior or a colleague to correct your papers. Practice writing exams. So case-based learning in the first 2 years, exam pattern-based learning in final year is I have classified it in such a way that it's for better understanding, but that does not mean that final year you should not see patients. Every time you have to see patients, you have to be with patients, but more exam-oriented like writing exams, all those things should come in the final year. Follow advice intelligently. There are so many advisors all around. Some person will say, you should definitely write notes, only then you will pass. You should read Harrison 2 times, only then you will pass. So you are all, I keep telling this, you're all adults. You should follow advice intelligently. What suits you, you should know. The next point is relaxation, balanced diet, exercise, sleep. Everything has to be there for good performance in exams. Practical exam is not the biggest hurdle. You should know which books to refer and the pattern, how to study for case presentation and viva. And you should know about what you have written in your logbook and your thesis. So practice case presentations, prepare OSCEs and case scenarios yourself. You can prepare. Today you are studying diabetes. You saw a patient of diabetes mellitus in the ward. You can just write his case scenario and ask 1, 2, 3, 4, 5 OSCE. You can prepare yourself. Again, relaxation, balanced diet, exercise, sleep, confidence is very important, but not overconfidence. And presence of mind is a key to success in any exam. And in post-graduation or in life, anywhere, there is no substitute for hard work. Thank you all and all the best to all of you. I hope all of you come out as very good and excellent family doctors. Thank you all.
Thank you, ma'am. Your support is always there for us. And once again, thanking you for being with us for the program. And next, we are moving to the last session of our today's program. I would like to welcome Dr. Jay Ganesh S., Registrar, Department of Family Medicine, KIMS Health Trivandrum, and FM 360 Coordinator, Spice Road, Kerala Chapter, for his speech on the topic Opportunities and Networking in Family Medicine. Welcome you, Dr. Jay Ganesh.
Ganesh, you are on mute.
Hello, everyone. Thank you for the introduction. And I think this is the last session. I'll wind up the session in 2 to 3 minutes. And after the elaborate session, like how you have to prepare for your studies and what all books you have to refer, what all study material you have to follow, and in which all organizations you should be part by your practice or during studies. Everything has been dealt in much detail. And just few points I would like to emphasize. And the believe in family medicine, because it's the #1 dominant specialty which is in the global level. Around 75% of patient contacts are in primary care. And as according to WHO, by 2030, around 30% of deficits, the shortage of GPs are expected. So if you work hard, if you come to the limelight, then there is a good future in front of you. And as discussed before, being a family medicine specialist, we should be the leader, we can be the leader in coordinating all the departments, all the specialties, because we are the one who is looking the patient, taking care of the patient as a whole. So there might be need of surgeon, cardiologist, nephrologist, neurologist, intensivist, and pulmonologist, etc. It is us who should be the leader of the team, and we should be able to be the leader. We should be specialized. We should be trained in that. So what are the career opportunities in family medicines? Actually, first of all, the clinical practice, as usual. Among the clinical practice, you can do private practice. You can have a hospital-based treatment like OPDs and IPD. You can go to the rural and or in the community health also. You can work in the emergency department. You can work in the critical care department, and the list goes on. Next thing is that you can contribute in academics and teaching. You can become a medical college faculty. You can be a director of the residency program. You can also contribute in curriculum development and part of a medical education research. You can also be the skills trainer and ACLS, BLS provider. And coming to the research also, the primary care lacks the research in this era. So you should take initiative because from the thesis, by doing the thesis, you'll be familiar with the research process. And after that, you should keep on doing this. You should contribute to the research, you do clinical trials and public health studies, etc. And coming to the policy and leadership, like as said before, you should be the part of AFPI, WONCA, and in India, we have got a very good support system that is a Spice Road movement. You should be a part of this movement, part of this association. And after that, government, you can be a part of government in hospital administration in whichever hospital you work. You can also pursue MBA. You need not be that much strict about it. You can also be a part of hospital administration without MBA because you will be familiar with all the departments after the end of your curriculum in the 3 years. And also in the Global Health Organization, also seek your advice. And beyond that, you can be a part of the health tech startups, insurance, medical legal things. And another main thing is that media and health communication. And that also, as family medicine specialists, we should be good communicators, and we are the face of the health system. We should be the face of the health system, and you are being looked upon by the patients. Like they will be asking questions, many doubts will be there, and even before the patient approaching you, you should approach the patient with a good communication, and you should utilize the media, social media especially. And you can also focus on palliative care, geriatrics, lifestyle medicine, diabetology, and many other subspecialties or areas of interest will be there. By the end of your curriculum, by the end of the 3 years, you can also get equipped with such specialized subspecialization. And while it can help in your practice also, you need not label yourself as a diabetologist or a geriatric specialist. You label it yourself as family medicine. You become a family medicine specialist, and with some focus on, with some interest on palliative care, geriatrics. That should be your tag. That should be your label. So key associations regarding the AFPI, already Dr. Vishnu has elaborated. Regarding the WONCA, regarding the Spice Road movement in India, it's a part of the regional working group of WONCA in South Asia, where young and the future family physicians, that is the PGs, postgraduates, as residents, you can be a part of it. As young doctors, that is after passing up to 5 years, you can be a part of it. You can contribute into the academics. You can make use of the academic programs, be a part of the training programs. And also, it is a platform where your leadership quality is being highlighted. You will be pushed. You will be given more opportunities. So you can make use of that. So Spice Road movement, you should be a part of it. You should be looked upon to it. Other organizations like AFP, it's our American Academy, they usually have conferences. They usually release guidelines and journals that you can make use of it. And you can also pursue MRCGP and be a part of the Royal College of GPs in UK. And networking strategies, as said before, be a part of the professional associations. And here we have got exchange programs. and various exchange programs we can be organized at local level, state level, national, as well as international level. As part of WONCA, there is a global FM 360 exchange program where there are exchanges going on, have been conducted, and we are expecting exchanges international level. And in that, from 1 week to 4 weeks, that's the duration of the program. That's where the observership will be organized between the countries, and based on various levels of expertise, the exposures and other institutes. In the institutes will be giving the opportunity to observe, to conduct the observership, and for that you have to communicate with the FM 360 coordinator of your country. And here in the South Asia, we have got the Spice Route, and the past few months back, we have done our first exchange program, that is FM Compass, in the state level, and we are looking forward to conduct it in the national level. And that is especially before the pre-conference. That is the 1 day prior the first day of conference, so that you can plan your travel. You will be already planning. Will be already coming to the conference. So if you are planning over 1 to 2 days prior the conference, we can have that that exchange program. And for that also, we'll be announcing the details. We will be announcing the curriculum of the exchange program, and those who are interested can also be a part of it. You can contact your state FM 360 coordinator or the national FM 360 coordinator for that. And that is actually brings you a more outlook to the family medicine practice, the various scopes of the family medicine practice, and also bring huge networking to come into practice. And next is CMEs and conferences of discussed before. You should present case reports. You should present research posters, be a part of the workshops. And also, if you are getting an opportunity to speak, to be a leader, take that opportunity, grab that opportunity. So you should attend all the national and state level CME programs, and as if it is possible during your your 3 years residency. And the most important thing, the digital networking and online presence. In this era of social networking and social media, it is very essential for you to come to the limelight. You should market yourself. Nobody will come to you to bring you to the top. You should come to the top. You should market yourself. You should be in the front of the social media, and you can use LinkedIn profiles. You could start an Instagram page or change your Instagram page to highlight your family medicine. That is the family medicine specialty. You can have an X Twitter, and in ResearchGate also you can be a part of it. And on WhatsApp, we have got many groups, especially in India, being a part of AFPI. There are many state chapters, there are many district chapters, there are zones, and there also you can contribute well. You can come to the front and make yourself get highlighted. And mentorship and peer learning. Being an intern or student, after that becoming a junior resident, you can become a senior resident and DNB. And most of the consultants will get stuck at that level. Being a faculty or being a leader is something special. Some hard work has to be done. Some homework to be done there. So for that, you should take a step now itself. Even if you are at the first year, this is the right time. Find a mentor, identify someone 5 to 10 years ahead, reach out at conferences or via association directories, and be specific about what you need. Like, you should be able to get an idea of what should be my area of practice. Like I said before by Dr. Rashmi, like that resident had an idea that I'll be practicing in my locality where there is much more need of a gynecologist. So that is the niche. That is finding the area of focus that should be that can be a good contributor to your future practice. And after that, be a mentor. While pursuing your post-graduation, you can guide your PG, you can guide your MBBS fellows, you can guide you can help your first years or second years, your juniors. You can lead general clubs, take initiative in academics, mentor to the DMB trainees, etc. And create peer learning circles, like form small groups of family medicine physicians and involve in monthly case discussions in audits of your hospital or clinics, and conduct or take initiative to conduct workshops. You have to request all the skills and workshops. The institute may not be that much keen to provide you all this training programs, but compare with or understand that the other compare with the most family medicine practiced, that is the real the institutes where the real family medicine being practiced. Understand the curriculum, do understand your deficiencies, and try to fill that, try to overcome it. And I've just put a 120 action plan on that. In coming 60 days, if you haven't yet joined AFPI or the SPICE route, be a part of it, join the AFPI. And next, optimize your social media profile with an FM expertise. You should be active in your social media. In nowadays, even the surgical specialty people were, we used to think that surgeries happen in OTs. No, nowadays, even the surgeons are coming to the line front, appearing in the social media and explaining about the surgeries, where the people, the patients or the society won't be understanding much. But still, it's a way of self-marketing. You should be utilizing the social media. So in the next 160 days, refurbish your social media profile. And as I said before, identify one mentor to reach out to and familiarize with the Journal of Family Medicine. We can utilize the AFP articles. The journal is being published in every month. In the next 90 years, attend one CME or conference at your local level, district level, or in your regional level. Submit an abstract or case report. It need not be an AFP account, that is the Family Medicine Conference. You can attend other conferences too. And if you are getting an opportunity, submit an abstract or case report. Join FM-related online communities, and set up monthly peer learning group also. In the next 120 days, volunteer for an association committee. We are having FMPC national level conference in September. So you can volunteer for association committees. Write one article or blog or social media post every week. That will increase your aversion. That will help in you overcome your aversion to the social media if you are a kind of introvert person. And explore your area of interest. Discuss with all of the senior practitioners, senior family medicine physicians. Discuss with your mentor and try to explore your niche, your area of interest. And schedule mentorship check-in quarterly. It should not be like, I have a mentor. Yeah, I'll call him. I'll call her whenever I need it. No, it should be like, keep in touch with that guy, with that mentor. And that is all about what I have to say about your opportunities and networking. The future of family medicine is in your hands. And I promise you that FM is the foundation of great healthcare, and you should believe in that. And opportunities are abundant, like clinical, academic, and policy making, and beyond that. But your networking has to be emphasized. Your network is your greatest career asset, and you should take one step today. Thank you for your patient listening. Thank you, Spice Road, for giving me this opportunity.
Thank you, Dr. Jaganesh, for that enlightening insights on exchange. As the past FM360 coordinator of Spice Road South Asia region, I just want to highlight one thing to everyone. So you all might be having some problems in your current institutes where you're having not much exposure to family medicine postings or what family medicine is. So there is an opportunity for you, so that where you can approach to any one of us that you want to get an observership for a few days. That is maybe 1 to 5 days. 1 day is very less, but still it's something is better than nothing. So you can have a 1 day training or something, observership or something. Or if you want to go to another place, like maybe if you want to go to another country like Sri Lanka or Nepal, you can reach out to us. That again is a possible thing. So that can be coordinated through the FM360 exchange program, which is coordinated by the WONCA, and we can easily facilitate it. So if anyone is interested, please reach out to any one of us. If you are not in the WhatsApp groups or the community of family medicine, please get the contacts of any one of us and reach out to us, or I can share my contact in the chat box. You can reach out to me. And one more thing, as Jay Ganesh emphasized, please be a part of the national conference coming up in Madurai in September 2026. That is on 25th to 27th. We celebrate the National Family Medicine Day also on that occasion. So please make sure you are a part of that event, because it is one platform where we all can come together and meet each other. So because it happens once in 2 years. So before Kiran moves on to the closing remarks, can I have just, for those who are possible, if you can just switch on your cameras so that we can have a snapshot of this wonderful event that we had for the last 2 hours. If it is okay with you, can you all please switch on the cameras? I'll just wait for 15 seconds for others also. So I'll take the click in count of 3. 1, 2, 3. Once more. Just one question I have in the chat box that was sent to me. So there were some people who have done courses other than MD, DNB and Diploma Family Medicine, like the PGDFM courses. Like if they want some clinical experience, what can they do is one question that I've received. Any insights from any of the experts? Rashmi ma'am or Sajida ma'am, you have any take on that?
You mean more clinical experience? See, they can always be part of your exchange program, no?
Yes, ma'am.
Or they're planning for a long-term observership. Long-term observership will depend on the institutions rather than institutional policies. But otherwise, always you can facilitate smaller exchange programs and all those things.
Okay. I'll just drop my number in the chat box. If anyone wants to have any further details, you can reach out to me.
Dr. Sajida has told that if you write to the Department of Family Medicine,
Yes.
some departments might service.
Yes, ma'am. I had a discussion with Dr. Venkatesh also last week when we met at the leadership summit, and he had sent me the email ID of whom I should be contacting. So officially to the principal office, we will have to write requesting a observership in the Department of Family Medicine, preferably for 3 to 5 days is what he suggested. So accordingly, maybe I can work it out. I'll coordinate with Dr. Bharat, who is the FM3C coordinator at national level, as well as the FM360 coordinator of Tamil Nadu state. I'm actually in contact with them. So we are planning it at CMC Vellore, CFH Odanchatram. We already had one in Lutz Hospital, Kochi, and another institute we have in our mind is Bangalore Baptist Hospital. So gradually we are trying to reach out to other places across the country. That is what is in mind at present. So I don't see any other questions in chat. Over to Kiran for your concluding remarks.
Good evening, everyone. Myself, Dr. Kiran, Secretary, Spice Route, Kerala. As we come to the end of this wonderful academic section, on behalf of Spice Route India Movement AFPA, along with Spice Route Kerala chapter, I extend my sincere gratitude to everyone who contributed to the success of today's event. Firstly, a heartfelt thanks to Dr. Rashmi ma'am for the highly informative section on curriculum examination and academic aids, which will definitely benefit all the PG residents. Next, I extend my sincere gratitude to Sajida ma'am for sharing the valuable insights on the core principles of family medicine. Next, I thank Dr. Hemavati ma'am for simplifying and beautifully explaining the concepts of three-stage assessments in family medicine. Next, I thank Vishnu sir for enlightening the session on key organizations in family medicine and for his continued leadership in strengthening the specialty. As you all know, sir is the backbone of Spice Root team. Thank you, sir. Next, I thank Dr. Aishwarya ma'am for beautifully explaining the scope and edit of family medicine to our young residents. Lastly, a special thanks to Dr. Jay Ganesh for highlighting the opportunities and networking possibilities within the family medicine community. A special appreciation to Dr. Sujitra, Spice Root Kerala Chair, for her opening remarks and constant support towards the academic initiatives of Spice Root Kerala. Lastly, I thank all the postgraduates who are present here for making this session so interactive and meaningful. As Vishnu sir already said, the program is a curtain raiser to the FMBC 2026, which happens once in 2 years. And I warmly invite all the PGs to register for the conference to be held at Madurai from September 25th to 27th, 2026. The first day, that is September 25th, will be the Spice Root PG Conclave and the PG Update session, which is specially designed for all the PG residents. For registration, group discounts will be active, and feel free to contact Vishnu sir or myself or any member of the Spice Root team. Looking forward to meet you all at FMBC 2026. Thank you once again.
Yes, I would also like to thank, there was many senior faculties apart from the PG's residents who have been attending this session. So I would also like to thank them on behalf of Spice Root. Shall we close the session?
Yes.
Yes, sir.
Sir.
Okay.